Uh, my name is Randy Korfman. I'm a reproductive endocrinologist from the Twin Cities. Our office is in Maple Grove, is where the main office is, but we have a program whereby I go around different places in the upper Midwest to see patients. So we have patients that we see in Great Falls, Montana, Minot, Bismarck, Fargo, Duluth, Minnesota, Wausau, Wisconsin, and we try to keep them with their local teams as much as we can. I grew up on a farming community outside of Wichita, Kansas, and really wanted to be able to provide care for people that live in rural areas. And that's the thrust of our program. I started out at Mayo Clinic after I finished my fellowship at Yale. Mayo Clinic hired me to come set their tested baby program up. They've been shut down for a number of years. Started to back up, and it was great, except they have a different model. They don't let you go out to see patients in rural areas, at least at that time. And so I left to start this clinic up in 1992. And so we really work to try to keep people with their local healthcare teams as long as we possibly can. Because I recognize growing up in a farming community that if you had to go to Wichita, it had to be something pretty bad wrong with you. And so it was a real impediment to try to get to good medical care. Fortunately, with the way things have transitioned in the last 20 years, we can provide just as good a care locally as we can with people coming here to the Twin Cities for care. So, and that's a tribute to the healthcare teams that you have in your communities. You know, each of these communities I'm talking about have really well-qualified OBGYN physicians who know what they're doing. They have all the technology in place for doing ultrasound monitoring, laboratory testing, preparation for other things. And so it's really a great thing. It's no longer that if you live in the rural areas, it's a significant problem for helping you conceive with relatively high-tech things. One of the things that I experienced myself was the fact that it was very difficult for us to have a child. There were things that we didn't have access to high-tech things at that point in time. And it was very difficult when family members were having no trouble conceiving, friends, relatives, and we were having difficulty. And one of the things that it helped me deal with this personally was the fact that if I could take and identify physicians who could explain things in a way that I could understand, it was really helpful. And so I think that what we try to do with our program is to make sure that people understand what they're getting into, what are the challenges at hand, and what are the problems, what do we need to do to try to fix them. And I really work to tell no one what to do. I rather try to give you information so you know what to do, because you know your own home situation, your financial situation, insurances, religious, ethical. Everybody has a different way of looking at things. And so I like to make sure that we just give it back to the patients to make up their minds on what they want to do. Now, part of that then is to make sure that they're aware of how the systems work. And one of the things that we learned with our patients over these many years is that many of our patients are having significant financial support from their family members, from friends, from relatives. And I think it's really good for you as a support network to appreciate what they're going through, what are some of the stressors that are going on for them, and some things you can do to try to lower the stress and anxiety in these people's lives. You know, talking about reproduction and having difficulty conceiving is something that is not innate for us. It's a hard subject to address. People don't talk about it, and it's really hard when it comes time for going to baby showers or to you know, family reunions and get-togethers where a premium is placed upon children, and it can be really disrupting to our lives. And so if you can reach out to your loved ones who are having difficulty conceiving and say, you know what, I understand some of the things that you're going through, and just want you to know we're here to support you. It doesn't have to be with money. It can be with just the thought that, look, I'm with you. I get it. We understand you're working on some things, and if there's anything we can do to help you, please let us know. And so with that in mind, my mission here is to educate you so you understand the system and what are the options involved. And then a little bit later, we're going to be going down the hallway to the in vitro fertilization laboratory so you can see what goes on with the in vitro fertilization process for those couples who need that. And so with that in mind, we're going to switch gears to a different diagram here in a minute, a different camera. One of the disclaimers I give to you is that in the farming community I grew up in, we didn't have kindergarten. And so my drawing skills and my social skills sometimes are not the best. So when I'm drawing these things out, so please forgive me for a lack of artistic ability, but here we go. Now we're going to a different camera. This is a poor artistic rendition of what the female reproductive tract looks like. And here's how it goes. The sperm start out in the vagina, and they coexist with bacteria that are normal for the woman to have here. Nature has a mechanism in place to prevent these bacteria from getting where they're not supposed to go in the form of mucus at the cervix and in this narrow part of the fallopian tube. So with ejaculation, the average guy is putting 200 million sperm into the vagina, and none will get through until she ovulates. And when she ovulates, not only does the egg come out of the ovary, but the little cells that surround the inside of this little cyst called a follicle, it contains an egg, and the cells inside of it make estrogen and then later progesterone. And those two hormones work together to control the cervical mucus to allow the sperm to get through. So let me zoom up here a little bit. So of those 200 million sperm, when things are optimal, there's only 500,000 sperm allowed to make it out inside the uterine cavity. And then it has to get through this mucus here, where the little cilia that line the fallopian tube beats out toward the end of the fallopian tube in that direction. And that will help push about 100,000 sperm out here. While that's going on, the same hormones are making these little cilia beat in a certain direction. So early on, when estrogen levels are higher than progesterone, these cilia go out in this direction. But when you ovulate and they turn around and go the other direction, the embryo then results from the tube picking up that egg. The process by which the tube picks up the egg, we don't really understand very well. We just know that it tends to happen. The egg is fertilized by the sperm out in the end of the fallopian tube. And then the little cilia then reverse their direction and they push the embryo toward the uterus. It bounces back and forth, the embryo does, between the tube and the uterus, eventually, hopefully, the embryo landing into the lining of the uterus. And once it does that, it starts laying down its roots and starts making the pregnancy hormone HCG. Now, it turns out that these embryos are genetically half the result of the male. And it's kind of a weird deal that nature will allow something to exist in a woman without it being her own. For example, these women who were taken care of, if they needed a kidney transplant, they couldn't just get one from their husband because he cares about her. It's got to be a close tissue match. But yet the uterus will allow something that's genetically not hers to exist without rejecting it. And the system prevents that by a series of antibodies that blocks the attacking of the placenta. But sometimes that goes haywire, and the antibodies come in, bind on the placenta, trigger blood clots to form, and that can lead to miscarriages because basically the embryo starves out. So that's the story. Now, it turns out one of the differences between your sons and your daughters is the fact that women are born with all the eggs they're going to have. So if we look at this on a time sequence, and I look at the number of eggs, it goes up and it comes down. So when you're at 20 weeks of pregnancy in your mother's womb, you had about 6 million eggs. And by the time you're born, 1 million. By the time she reaches puberty, she's down to 600,000. And when she gets to be 50.7 years of age, she'll run out of eggs. Now that's the middle of the bell-shaped curve, you guys. Some women, we've seen women run out of eggs as early as 12, 13 years of age. And Sarah in the Old Testament was like 88 years old when she quit having kids. So you're in here someplace. We don't exactly know where. We just know that one of the things that is true, that if a woman is 35 years of age, her eggs have been around for 35 plus years, and that allows the accumulation of genetic damage in some of those eggs. So it turns out about half the eggs have major genetic abnormalities in a woman who's 35 years of age. And that's an underestimate because that's looking at 6 of the 23 chromosome pairs. So if we look at all of them, for a woman who's 35 years of age, there may be 70, 80% of her eggs are genetically abnormal. Now, what does that mean to us? It means that nature's got a challenge to make sure that we don't have genetically abnormal kids. So here's how this works. When a young woman goes through puberty, her brain became able to think that eggs and estrogen go together. Her brain measures that in the hypothalamus. The pituitary gland, another part of the brain, makes this hormone follicle stimulating hormone that goes through the bloodstream into the ovaries, and this hormone level rises in the bloodstream in the ovaries where these follicles are scattered. So this woman at age 35 is using up her eggs at the rate of 10 to 30 a month. She's using up the rate of 20 to 50 a month when she's 30. So as she's having fewer and fewer eggs left in the ovary, the brain works harder and harder and harder to continue squeezing egg out of the ovary. So she saves one egg, and that egg that is saved not because it's the best egg, but it's saved because it can pick up the blood supply better than the other ones. So if you save a normal one and a sperm at the right place at the right time, it's going to work. But if she happens to save an abnormal one, it's going to shut it down someplace. So if it's really abnormal, it won't let the sperm in. Or maybe normal enough to do that, but not let it divide, or not let it hatch, or not let it implant. That's what leads to about a 16% chance for a woman who's 35 years of age to conceive in a given month. But if you have one that makes through all those hoops and is still abnormal, nature's going to cause you to have a miscarriage, and that's why the miscarriage rate at age 35 is 20%. Okay, so now we can look at it one of two ways. You can look at it one way and say, wow, you mean for a 30-year-old, there's only an 18% chance of getting pregnant each month? Yeah. That sounds pretty bad. But in reality, I think the other way to look at this is that nature is really good at making sure that we don't have a genetically abnormal child. And it will shut it down someplace and not enable that embryo to make it. But sometimes they will sneak through. For example, Down syndrome or some other chromosome abnormalities that may not be normal, but may not be life-threatening. So that's the story. And so when you're 30 years of age, about a fourth of them have major genetic abnormalities. When she's 40 years of age, 85% of them are genetically abnormal, and you can see the success rates of getting pregnant each month goes down with time. When she's 42, over 95% of her eggs are genetically abnormal. That leads to much lower success rates, and the number of eggs she has is lower. Now, this is important for us to consider this chart because it's a little oversimplistic, but not too much. It turns out that this is like a bathtub. And in that bathtub is a faucet with filling up the bathtub with water, with eggs. And so there's 6 million of them when you are halfway through your mother's pregnancy, but it's down to 1 million by the time you hit birth. And this drain will let whatever's coming through come through, and it's going to save one of those eggs is coming through that drain at that point in time. So for this woman who's 35 years of age, she may be dumping out her eggs through that drain at the rate of 10 to 20 a month, but she's going to save one, and it just continues like that. So I think that's a good way to look at it from an ovarian reserve standpoint. Now we have some testing that we can do to see about how many eggs a woman has remaining. Now these numbers go according to the woman's date of birth. Now why are we focusing on the woman's date of birth? Well, a guy is making new sperm all the time. Sperm lasts 72 days. So there's always new sperm being made, and so our age doesn't make the difference that it does for a female. But in recent years, it's become more obvious to us that when a gentleman gets to be over 42 years of age, there's an increase in the risk of miscarriage, autism, and some mental illnesses in the kids that we father. So no longer does the guy get off the hook entirely when it comes to the impact of age upon fertility. There's both of them contribute to it. And so it's just important to know that. And so then couples can make some decisions about this. Now, sometimes, and most often when I see couples that are having trouble conceiving, it is just because of the fact that the brain is not making enough follicle stimulating hormone to save a follicle. And all we got to do is make this go up a little bit. And so I would say that for 70, 80% of our couples, all we need to use is some oral fertility medications to make this go up a little bit. But sometimes we have to use in vitro fertilization, which takes advantage of this knowledge, knowing that instead of making this go up just a little bit with some oral medications, the woman can take injections of this hormone 2 times per day for 10 to 12 days and save all of them that are coming out that bathtub drain at that point in time. And good ones and bad ones. We don't have a way of teasing the good ones out and leave the bad ones behind. So that's the challenge that we have when it comes to in vitro fertilization. And our challenge when we're using oral fertility medications is to make sure that when we make this level go up, we don't make it go up too high, because sometimes it'll go up that high, which puts her at risk of having twins or triplets. Or it might go up this high or this high. We don't want it to go up making more than 2 or 3 follicles, because we want to keep you out of harm's way in terms of multiple pregnancy rates. So 1 is perfect, 2 is acceptable, but it becomes a high-risk pregnancy. So we really do our best to try to make it so there's only 1 there, but it's not as easy as just making it go up a little bit. Sometimes it swings wildly, and we can't be confident that we're only going to make 1. So we just know that, and we go into it knowing that if we're using oral fertility medications, there's about an 8% chance of multiples. Now, back to this drawing. When we evaluate things, we have to make assumptions about these systems. And these are assumptions because of the fact that we can't track the sperm and eggs, are too small to see. We just know that we'd like to assume that the sperm are okay, that her eggs are going to work okay, and that her fallopian tubes can function, that her uterus can function, and that she is a host are okay. Host meaning that she's not a smoker and that she's not above a body mass index of over 30. It turns out if a woman's body mass index is over 30, there becomes some significant risks involved with her carrying a pregnancy and delivering a healthy baby. We also know that it makes the eggs not work as well if a woman's body mass index is over 30. And we encourage them to get their body mass index down before they conceive, before we have a reasonable chance of making fertility medications to work. Now, that is something that a lot of young couples do not want to hear. If we see a young couple and she needs to lose 20 pounds or 10 pounds, that's doable. But if they have to lose 50 or 60 pounds, sometimes that is not easily doable. And they may need to seek help from a surgeon or from internal medicine physicians to help them lose weight. You happen to have a really good internal medicine physician in Fargo, North Dakota, who does a great job with treating obesity and getting body mass indexes down. Same thing is true for a guy. The guy, if he's overweight, it makes his sperm function not work appropriately. And let me just show you how that works. It turns out that the woman's brain thinks that eggs and estrogen go together. The guy's brain thinks that sperm and testosterone go together. This same hormone goes from our pituitary gland as guys into the testicles, where we make sperm and testosterone. We don't know if we're making sperm, we measure testosterone. She doesn't know if she's making eggs, she just measures estrogen. It turns out that stress hormones made by our adrenal glands can be converted into an estrogen and into testosterone, and that is mediated by fat cells. So if we're really trim, we don't get much conversion of this no matter how much stress we're under. But if our weight is above a BMI of equal to or greater than 30, that alone can make the testosterone levels and estrogen levels become a problem. So that's the deal. It's not that I have anything against people that are overweight. In fact, my mom, she was the best cook in the state of Kansas, but she had obesity and it ended up contributing to her life ending much earlier than it should have. And I just don't want to see anybody else in that position. So even though I'm 68 years old now, I still miss my mom and wish she was around, and I just don't want this to happen to somebody else. So while it's not easy, losing weight is something that your kids, your family members who are going through infertility may need to do to make this have an optimized chances of working. And you'll see when we're getting into some of the more expensive alternatives, getting that optimizing the chance for conception is really important for the investment that they're making or the investment that you're making in trying to help these our children have kids. So that's how that works. Now, the way we start out with this process is we start out looking at sperm. Now I want to show you another diagram here to demonstrate my lack of artistic ability. This is supposed to be the testicle. And the testicle is sitting there, and it's got a gland on the side of it called the epididymis. The vas deferens comes out of the epididymis through the prostate, where these two glands. Sperm in the testicle are round. They find their way into the center part of the testicle, come into the epididymis where they develop a tail. By the time they come out these channels on the other end of the epididymis, the tail is wiggling. That's supposed to be a wiggling sperm. And it comes along and there's a cap on the head of that sperm. The contents of these glands strip that cap off, exposing enzymes that are necessary for chewing their way through the eggshell. And that's called capacitation. And then the sperm comes out and ready to do their thing. Now, it turns out that there's a muscle that raises and lowers a testicle to keep it 1 degree cooler than our core body temperature. So we raise and lower our testicles to keep them at the right temperature. That's why hot tubs are thought to be a problem for sperm production. Our concern with this system is that there can be interruptions such that there's a barrier between our testicle and our bloodstream, and that testicle bloodstream barrier can be transgressed. So if a little boy or a young man has a testicular trauma, like gets hit with a softball or a baseball or a hockey puck or a stick, or you know, who knows, it can cause entry of some of these sperm into his bloodstream. We recognize it as being foreign. We make antibodies against that foreign substance, and they can be concentrated in these glands. So when the sperm comes along, the antibody molecules can bind onto the sperm and immobilize them and make the motility go down. And that becomes a problem then for conception for some of these guys, that their motility is all bound up and they simply can't get sperm to go through the cervical mucus. So I want to kind of go through one step at a time what we do with the system. First off, we start out with a semen analysis. Semen analysis, and I'm not doing a fancy PowerPoint slide because I think it kind of limits communicating information to you today. So that's why I didn't put together a PowerPoint slide for you. So hopefully you can read my handwriting so you can see what I'm talking about. Sperm counts are performed, and if it comes back normal, we're good. We're happy with that. If it comes back abnormal, there's two things that we can do to deal with that. We can do in vitro fertilization with a technique called ICSI, where we can take the sperm and directly inject it into the egg. Maria Norris, our one of our embryologists, is going to be talking to you about that in the laboratory here pretty soon. Another way of dealing with it is to do intrauterine inseminations, which means to take the sperm sample, spin it, get rid of the immobile sperm, slide a catheter in, and squirt the sperm right into here, bypassing that drop from 200 million to 500,000. So we can put in several million sperm, and that tends to increase the pregnancy chances. Sometimes it is fixable, meaning that there can be some medication or surgery performed by a urologist that specializes in male factor infertility to help improve sperm function. So that's how we use that information. Those are the technologies that we would use. For ovulation, for eggs, we can use some medications to increase the follicle stimulating hormone level to make it so this woman ovulates. So if she's only making FSH up to this level, we can give her an oral medication that tricks her brain into making more follicle stimulating hormone, and suddenly she begins ovulating. And then we have that under control. Since you know from this chart that ovulation hormones control absolutely everything, it's really important that we have that under control and we have good ovulation events, and we know how to do that using ultrasounds to monitor the development of these follicles. There are times when we have no eggs, that we suspect that the woman has run out of eggs prematurely. In those cases, we can use donor eggs. Now there becomes some ethical issues there. For example, what if the guy's sperm count is abnormal and we can't fix it, or there's no sperm there? Donor sperm becomes an option. Now that therein lies why I like to just present our patients with the options. They can decide what they're okay with, what they're not okay with, because sometimes that will be an ethical dilemma that they're just not willing to utilize, which is fine. Then they need to go back to the drawing board to figure out what is okay for them and what isn't. There are times when we have problems with the egg coming out of the ovary. So if you got the ovary sitting here and you have a follicle, let's say this woman is ovulating 2 eggs in 1 month. There's the eggs. If she has scar tissue covering over the ovary, this egg is going to be stuck and can't get out. This egg can get out. And sometimes if there's enough scar tissue, it would mean that the egg is simply fertilizable, but it can't get out of the ovary, and that's where in vitro fertilization comes into play. With in vitro fertilization, we can harvest her eggs. We can put them together with the sperm to give embryos, and then off we go. So that's how we can use that to improve the outcome. I would say that the vast majority of couples we see, we just simply do this, and that tends to make ovulation occur. It tends to increase the chances for the number of targets for the guy's sperm to hit, so we can treat mild male factor infertility with that. And we do that in conjunction with intrauterine inseminations. All those things can be done locally with the local health care team there in North Dakota or Montana or Minnesota or Wisconsin. What about the cervical mucus? That cervical mucus is there, and it's there to prevent bacteria from getting through. And sometimes it has characteristics such that it makes sperm not able to get through. We really don't have a test to be able to assess that. But if we thought that was an issue, we could do intrauterine inseminations. The guy gives a sperm sample, we prepare it, slide a catheter in, and squirt the sperm in about the time of ovulation occurring. What about the fallopian tubes? There's some tests that can be done in a non-invasive way to find out if the tubes are blocked. So this test, called a hysterosalpingogram, is such that we block off the cervix, we put X-ray dye inside the uterus, it fills up the uterus, and the dye comes out through the tubes. So it's diagnostic to show that the tubes are open, but it also tends to be therapeutic in that it flushes mucus out of that narrow part of the tube and enhances the odds of this woman to conceive. So we have a way of getting around that. We can do in vitro fertilization, because with in vitro fertilization, we can harvest our eggs, put them together with the sperm in a petri dish, bypass the fallopian tubes completely, and then put the resulting embryos back inside the uterus. What about the uterus? It is very difficult to repair the uterus. And it is an issue that sometimes we can do surgery to fix it. Fortunately, you folks are all blessed with physicians in your local communities that are skilled at doing these kind of surgeries, even using robotics, so it doesn't require a big surgery, big incision on your abdomen. Sometimes it's not fixable, and that would lead to a thing called gestational carrier. Gestational carrier means we take the eggs and sperm from a couple, have embryos result from that, and then put those embryos back into the woman's uterus who's carrying the pregnancy for them. Now, there's ethical and legal issues that occur with that as well, but it's definitely possible and something that we've done in North Dakota for a number of times. I'm going to just concentrate on those right now. There are sometimes immune issues that can happen whereby the woman thinks that her embryos are genetically not hers and she attacks them and gets rid of them. That's a very difficult problem to deal with, and it requires some extra manipulations with hormones and some things to prevent blood clots from forming. So I'm not going to delve into that. But that's the basic overview of what we do for couples that are trying to conceive, that are having trouble conceiving. And those are the treatment options that we have for those couples. Now, I want to change gears for a minute. And after telling you again that most couples we see do not need in vitro fertilization, they can do just superovulation. But after we do these testing for these couples, we have a meeting, and that meeting goes like this. Here are your options. Whoops, that is not focusing. Let me refocus this. Sometimes for some reason, focusing that camera on my bald head makes this clear out. There we go. It did it again. This couple may decide to have no children. They may decide to adopt. They may decide to do some oral fertility medications that we use a drug called letrozole, with or without doing intrauterine artificial inseminations. And we don't do that more than 4 to 6 times, because if it doesn't work by then, something else is going on. We could do in vitro fertilization with, we'll say, Susie's eggs and Jimmy's sperm. We could do in vitro fertilization with donor eggs and donor sperm. Lots of different permutations of this. And it's just important then for these couples to understand what the testing has shown and what the options are. Now, all these tests I just showed you can all be done within the course of 1 or 2 months. So it doesn't take very long to figure out what's going on and what the options are, but they make their decision of what they're going to do. And they might choose different things. So for example, here's what I do. This is from a couple that I saw recently. This couple, She's 32. He was 34 years of age. They could do letrozole, the oral fertility drugs. It's about $12,000 by the time they go through 6 months of it. It's about $2,000 a month to do it. Insurances may or may not cover it. That's when they may need some financial help. 60% chance of working, 8% chance of multiples. She's a genetic mother. He's a genetic father. She's carrying the pregnancy. It's expensive. They could do in vitro fertilization. It's about $20,000. In our program, there's about a 50% chance of a delivery putting in one embryo, less than a 1% chance of it splitting in identical twins. They may choose to put in 2 embryos, which increases the likelihood of it working, but it also increases the likelihood of multiples. She's a genetic mother. He's a genetic father. She's carrying the pregnancy. They need to manage the risk of multiples. What if she had testing performed that says her ovaries are not working to the point that there's not enough eggs to go through the in vitro process? They may choose to use donor eggs. We pay the donors about $6,000 to donate eggs. They have a 55% chance of a delivery putting in 1 embryo, 74% chance putting in 2 embryos, but a high multiple pregnancy rate. She's not the genetic mother. He is or is not the genetic father. It depends if we use his sperm or donor sperm. There's ethical issues involved with that, and they need to manage the risk of multiples because it works really well. They may choose to adopt. $18,000 to $40,000 to adopt. They have high chances of adopting. 1% of adopting multiples. She's not the genetic mother. He's not the genetic father. She's not carrying the pregnancy. It's expensive. There's ethical issues there ×2. And a big one for us is that we don't know much at all about the health of the mom or the dad and what habits they might have. Are they using drugs, alcohol, you name it? There's some unknowns there. That's what will lead some couples to choose these other alternatives. Many times I'll see couples and they say, well, look, if we're going to use donor eggs and donor sperm, we might as well adopt. Well, this becomes the big difference between these two and this. And we know with donor, they're picking the donor. These donors have been screened out the wazoo. They know about their genetic history. They have no major medical problems, and they would be expected to be passing off good eggs and good sperm. But that becomes an ethical dilemma. What about a different scenario? What about if she's 40 years of age? And let's say he's 38 years of age. Going through letrozole works less well with them. Instead of a 60% for a woman who's under 35 years of age, it's only a 20% chance of a delivery at age 40 after 4 cycles of this. They have about 8,000 into it. Compare that with in vitro, about the same. Look at with donor eggs. You have high success rates, but then you have the ethical dilemma that goes along with the fact that you're not using that woman's eggs. Sometimes they'll choose donor embryos because sometimes we have couples who go through in vitro. They do not want any more children. They're willing to donate their embryos to somebody else. Not the genetic mother, not the genetic father, but she's carrying the pregnancy. So it's like a super adoption, in my opinion. The only problem with it is it's a 1 to 2 year wait for these. And there's many programs just will simply not use donor embryos for reasons that I'm not really sure. But if we have them available, we just suggest that people consider donating them to other couples. Okay, so that's the deal there. Now I wanted to change gears here one more time and to show you how the in vitro process works. We harvest the eggs, and on the day of the egg retrieval, we put the sperm with the egg one way or the other. We call that day 0. The way we harvest eggs, by the way, is to put an ultrasound probe into the vagina, and it turns out the ovary is sitting 1 centimeter from the top of the vagina, so it's very close. So it's real easy to put a little tiny needle up through the vaginal wall into the ovary. We just suck that fluid out. The eggs come with it. So there's no surgery involved with this. We don't use a general anesthetic in our program. I know many programs use general anesthetics to put their women to sleep for their egg retrieval. We'd rather not do that because of evidence that we feel shows that the general anesthetics are hard on the eggs and the sperm, hard on the eggs. So we'd rather not have that toxin around. And we just sedate with some IV sedation and make sure the woman is comfortable, and her recovery is much more rapid. So we get the eggs, put them together with the sperm, one way or the other. What I mean by that is sometimes we just dump the sperm on top of the eggs. Depending upon the guy's sperm count, sometimes we inject a single sperm into the egg with this technique called ICSI. Maria will show you information about that in just a minute. We take the eggs, look at them the next morning, and we can see the nucleus from the sperm and the eggs. It's called a pronuclear stage, one cell. By day 2, this is up to a 2 to 4 cell stage. By day 3, it's up to a 6 to 8 cell stage. And by day 5, it's up to 80 to 100 cells, called blastocyst. And that's the day that we like to put embryos back in. We can grow the embryos one more day out to day 6. It's up to 80 to over 200 cells at that point, but they have to be frozen. They're out of synchrony with the line of uterus by then. So we, in our program, and every program does things differently, but let me give you the rationale about why we do it the way we do it here. We feel that the woman's uterus is a better incubator than our incubator. So if we're sitting here on day 1 and we only have 1, 2, or 3 embryos, we'll do an embryo transfer on that day if there are less than 4 embryos. But if we have 4 or more, we do an embryo transfer on day 5. Because these embryos then have jumped over hurdles for a number of days, and it tends to weed out some of the less genetically normal ones, thereby enriching our chances of picking out the ones that are going to work. And that's why success rates are better if we put them on a day 5, only because it's a selection advantage. Now, we have couples occasionally who come see us who have a genetic abnormality that they do not want to pass off to their children. Like they both might be carriers for cystic fibrosis or hemophilia or that sort of thing. We can take 3 or 4 cells out of the embryo on that day, do genetic evaluation. It takes a day or 2 to get the answer back. By then it's too late to put them back in. We freeze the embryos, wait for the answer to come back from the genetics lab, and then 2 months later, do an embryo transfer. And we can then determine a bunch of things about the genetics of that embryo. So we can determine Down syndrome. We can tell male, female. We can tell if they have single gene defects, whether that embryo is the carrier or going to be affected with the disorder. And then the couples can make a decision to use them or to donate them to other couples or to discard them. Same options that the couple who do not do genetic evaluation. They've got to use them. They can donate them to other couples, or they can discard them. We don't like to discard normal embryos here at our program. So we really encourage couples to be clear when they let us work with eggs that they have to assume that every egg could turn into a baby, and to be responsible for every embryo that they make. Nowadays, we can take some of these eggs that they don't use and freeze them and use those down the road if this other stuff doesn't work. So that becomes a way of getting couples out of the ethical dilemma about limiting the number of eggs that they're letting us use. You don't create more embryos than they're willing to use. We don't do this evaluation routinely in our program on every embryo coming through because we think it's an overuse of the technology. It drives the cost of the process up by at least $10,000 to $12,000. and we think it's just basically an overuse of the technology. But if a couple have those genetic problems I was telling you about, that's a different story. Frozen embryos can be frozen forever. There's no length shelf life on these things, and they can be used a number of years down the road. There's about a 2-year waiting list for people wanting donated embryos. So there's an out for couples that are wanting to go through the process but are worried about what to do with the other embryos to make sure they're going to be used. That is kind of an overview, I think, of how of all the technologies. I'm going to shift gears now, and we're going to go down and meet a special person. Maria Norris is a PhD in our lab, and she is an awesome person. She's one of 3 that we have working here doing the embryology on a day-to-day basis with our in vitro program. And so I'm going to take you on a quick tour down the hallway down to our in vitro fertilization laboratory. So with that in mind, I'm going to change the gears for this to a different camera. That's the fish, and I like trout fishing. And I'm going to change the view of this to the full screen. I think I am. Okay, so here we go. Going down the hallway here. I don't want to show you my office is cluttered, but I like it. I know where everything is. So here's our hallway. Going to go down hallway. This is the entryway. There goes one of our nurses scurrying across the hallway. We have procedure rooms, and this is the hallway leading down to our in vitro lab. We have pictures of our babies up on the wall, or some of them. We like that because we like to give people hope to know that this can work. There's kind of the Hall of Fame, so to speak. And we're coming down here to the in vitro lab. This doorway is the door into the room where we harvest eggs. And we come into the procedure room here. This is laboratory where Dr. Norris is sitting over there. This laboratory is where the sperm are prepped. The sperm are passed through those windows. They're immediately looked at with the microscope. They prep them and for use for either doing intrauterine inseminations or for doing in vitro fertilization. Dr. Norris, I already talked about you, so they know a little bit about you, and if you could give them a tour, and I'm going to follow along with you.
Sure. So we'll start in the andrology side just a little bit. Not too much to look at in here. Our primary tool is the microscope, and we're going to use that to look at how many sperm are motile, whether their morphology, which is the shape of the sperm, is normal. We can also do a staining that allows us to see how many sperm are live or dead to assess the viability of a semen sample. And then we also will measure the volume of the semen, which we use our pipettes over here.
Super.
All right, let's go on in to the
I'll follow you.
IVF lab, and
Okay.
we can look at a semen sample in there and see where all the magic happens.
Super. What are these, Maria? Are you going to show this later, or you want?
We can talk about them
Okay.
now. These are our liquid nitrogen cryo storage tanks. So within them we have oocyte, embryo, and semen samples frozen and stored. There's not a ton of, actually there shouldn't be any embryos in them right now because we do all of our storage off-site with ReproTech. So there's just semen in them at the moment.
Super. Thank you. I'll follow you. I'm good.
Okay. Ivf Laboratory. See, a lot of things are shut down over here since we're not currently up and running with that right now. But there are a few things that I can show to you. We just talked about sperm and semen. So I put some up on the computer here for you to see. This is a very normal looking semen sample. The concentration is above the 15 million per mil, which is documented as normal from the World Health Organization. Motility was over 40%. You can see lots of sperm spreading throughout the screen. And over 40 is again considered normal based on World Health Organization parameters. So
Super. Thank you.
All right. Over here is our retrieval window. So one of the first things we get in the IVF laboratory is eggs, and those are going to come through the window. We use this scope here to search through all the follicular fluid, and that's the fluid that is removed from around and within the ovarian follicles to search for eggs.
Super.
And then the eggs will be inseminated either by routine insemination or conventional insemination, which just involves mixing your eggs and sperm together within the same drop. Or we can also inseminate through a process called ICSI, or intracytoplasmic sperm injection. And I have a video for you here of that process. We can see the egg here. We know it's mature because there is a polar body located at the 12 o'clock position. Here's our ICSI needle, and there is a sperm right there that they're getting ready to inject. So it's a fairly fast procedure once you know what you're doing, but you're going to aspirate a little cytoplasm or cellular material from the egg to break that vacuum from the inner membrane, inject the sperm, and then you're done.
Awesome. Super. Thank you.
All right, so once ICSI is performed, the next day we will come in and check for fertilization of those eggs. And we can see an example here of a 2 pronuclear egg. So it has 1 pronucleus, which is your DNA from the sperm, and 1 pronucleus here from the egg. Each of them has half the genetic material required. So together we have a full set of genes that can develop into a child.
Great.
Those are going to get cultured in our incubators. We have 6 of them in this laboratory. These are big box incubators. They also have smaller incubators as well. They come in all shapes and sizes, but the important thing for these is that they have a low CO2 concentration. And that will allow the correct pH to mimic the uterine environment or fallopian tube environment where embryos are normally grown and cultured in the body. We can mimic that here with these. So over the course of a few days, you're going to see embryos develop. Here's a 4-cell embryo in this image. And then that's going to go on and develop. So we have 1, 2, 3, 4, 5, 6, 7, 8, 9. I'm going to guess this is about a 12-cell embryo here, so a little further in progression. And then eventually, what we want to see is blastocyst development. And a blastocyst here's an example of an early blastocyst. So what happens is all those cells kind of merge into think of it like a basketball with a golf ball stuck inside. So this basketball layer is your trophectoderm cells, and those are going to develop into the placenta. And this is your golf ball size amount of cells that's stuck to the inside. And that's called your ICM, or inner cell mass, and that's going to develop into your baby.
Super.
Depending on your course of treatment, you may want to do a biopsy on your embryos to determine whether they are aneuploid or normal, meaning do they have the correct set of chromosomes? And that's something else we can do here. I couldn't find any videos of that, unfortunately.
I drew out a picture for them.
Perfect. So they have an idea of that, but that will also be done on the scope where we do ICSI as well. And it's also going to show you a little bit. So what happens once we get a beautiful blastocyst? Two things, we can transfer them. So this is a transfer catheter, obviously not one we're going to use, but this is an old one. And we can see this inner sheath here, and this is where your embryos are going to be loaded up into. And then there's this guide catheter to help us keep our embryos safe, because as you can see, once you remove it, it's kind of a limp noodle. So we keep this on to keep the embryos safe until the final moment where they are transferred into the uterus. And the other option for blastocysts, if we're not transferring them, we're going to freeze them. So if by chance you aren't successful in your fresh cycle, you can come back for a frozen embryo transfer.
Super.
And this is the device that we use to freeze them on. It's called CryoLock. A lot of other labs use something similar, Vitrogard, CryoTip. But there's just a thin piece of plastic here that the embryos are loaded onto to be frozen. We use a cryoprotectant, which allows for the fast cooling of embryos. And what happens is it's submerged in a solution with sugar and other solvents, and that allows that when they freeze, the water inside the embryo doesn't crystallize and form sharp shards and puncture and destroy the cells of the embryo, but instead it does not really cuboidal, but so the ice, when it forms within the embryo, doesn't puncture and destroy it.
Ice crystals are a bad thing.
Yes, yes, very bad. So we use a process called vitrification, which works really well. We have about a 95% rate of thawed embryos surviving, I believe. So.
Super.
All right.
Okay. Thank you, Maria.
You're welcome.
So now I'm just going to set this down here. So the story here is that I hope that you, as family members or friends, providing support for these couples, can know that your family members or your loved ones are going through some difficult procedures, but they can be very successful. And your friends and relatives have some really good options available to them if they want to use them. It takes a team approach to make this happen. Not only with embryology and with the physicians, but also with the nurses are a critical part of making this a successful process, so that people can get it through it without losing their minds and without going bankrupt is the plan. So with that in mind, I think I'm going to call it a day. And I hope if you have any questions, you can let Tara know at Everlasting Hope. We really greatly appreciate Tara's taking the reins and getting this organization off the ground and providing support for couples who are going through a difficult part of their time. And I want to thank you as family members for taking time to watch this video. I know you have better things in your life that you could be doing now other than listen to us talk, but it was really nice to be able to allow you to do that. And we hope that you can call us if you have any questions and talk with your healthcare providers. So thanks a lot. We wish you the best of luck and have a great day. Okay, bye.